changes. Before that, do we know about the definition? So this is the global definition that was introduced in 2021. Actually, there was a older definition kept about, but they redefine it. They define it as PBM is patient-centered. So they added this patient-centered, systematic, evidence-based approach to improve patient outcomes by managing and preserving patients' well-being while promoting patient safety and empowerment. So Dr. Zalila mentioned about patient safety. This is one program that we should look into to introduce access program to improve patient safety. So in short, if I look at this definition, what we pop up in mind is PATI. You are supposed to be PATI. All right? You build your own blood bank in another word. Now, PBM is not here. The next WHA World Health Organization, I think in a week or two, but this has been introduced even in 2010. All right, World Health Organization, they have mentioned about it, but we are not too. We call up pretty fast in Malaysia. We call up by around. I'm always told it's 2012 or 2014. They're about. So we are pretty fast. In Southeast Asia, we are front runner, frankly speaking, but it doesn't mean that it's being practiced. Similarly in every sector. So that's where the challenge is. So when we talk about PBM, we need to know about the 3 pillars. For those of you who are familiar, PBM is synonymous with 3 pillars. What are the 3 pillars? You have pillar 1, 2, and 3. Pillar 1 is essentially about academia, management and management, prevention. Pillar 2 is minimizing blood loss. All right. And it means that for us, you are nutritionists, so on so forth, what are your nutrient coverage, your clinical management strategies, and right. Pillar 3 is leveraging and optimizing patients' specific physiological problems. So more or less exactly to how now all these 3 pillars can be applied in 3 phases.
Because you don't see a motivation for you to continue. And mind you, every changes is painful, right? So you need to be motivated enough. So why is that so? It's because PBM is very important, as we all need iron in the optimal functioning of every cells in our system, right? And it is a most effective approach. You spend less to achieve best outcome. Nowadays, we are talking about blood health. So when you are asked which is the most important organ in your body, people will talk about heart, brain, kidney, but actually it's blood health. If you don't have good blood health, the rest of it will come secondary. Okay, and you can see healthy pregnancy is one of it. Now, in what is NAID? It's not anemic iron deficiency, or we call it ID, iron deficiency. Even as early as just deficiency before reaching anemic, it has been proven to be detrimental to mothers. Okay, so the effect is the same. What are the effects for the mothers? You can't tolerate blood loss. I often tell my patient, if I top up your HB to 13, even if you lose 4 grams, your HB drop to 12, lose 4 grams, your HB drop from 13 to 9, compared to someone who started off with 11, you drop to 7. So your risk is higher if you to begin with without as good a HB as compared to those with 13. So you can't tolerate blood loss as well. And the moment your number reaches low and the patient's hemodynamic changes, and you tend to want to transfuse. And there's a risk of severe maternal morbidity and mortality after PPH, increased risk in heart failure, reduced milk productions, early cessations of breastfeeding, shorter lactation periods, perinatal mental health. Dr. Mashta mentioned about mental health. It is something that we cannot ignore. All right. Why? Because can you imagine physically you cannot function as well. You tend to be feeling low, depressed, fatigue, and impact connection, impact physical functions, and reduce quality of life. All these things could contribute to SDG target 3.1. How about baby? How about children? Similarly, I'm sure you'll notice there's a lot more FGR, SGA, low birth weight, premature birth, and perinatal mortality as well. And of course, ID or IDA in the newborns and children. There is also long-term adverse effects, especially for brain development and behavior. So they have found association between autism spectrum among the children with maternal anemia. All right. So remember, all these things are essential for our better future. We being in a surgical discipline, we are fairly familiar with the little trial of coagulopathy, metabolic acidosis, and hypothermia. I'm sure you are aware. If a patient bleed torrentially, these are the vicious cycle. But I also want you to take one step behind. Before you reach the trauma triad or little triad of trauma, think about the hematological risk, the trial of hematological risk. What do I mean by that? If a patient is anemic, you are at risk for hemorrhage. When you are at risk of hemorrhage, you are at risk for transfusion, all right? And transfusion, and because of blood loss, again, is going back to anemia. But these three are modifiable if you implement it PBM soon enough. So they are all independent risk factors for adverse outcome, but it's something that we can modify. We do have a challenge in terms of anemia. All right. Unfortunately, in WHO classification, we are classified as moderate prevalence. That means your prevalence of anemia among pregnant women. I'm talking about anemia. I'm not even talking about iron deficiency. So anemia, because it's easier to monitor, you look at your HB. Those less than 20% prevalence anemia in pregnancy are considered as mild. We are almost reaching severe. We are still moderate. That means 20 to 40%. But depending on certain region where you are sampling taking the sample from, there are some states that is more than 40%. If you're more than 40%, you are considered as severe. All right. So we are at moderate prevalence of anemia in pregnancy, and that call for routine hematinic administrations for pregnant women. That's why we do routinely. It's because of that. But if your prevalence is less than 20%, then you don't need to do routinely. Now, how about PPH or PPH leading to MMR? We are still not doing well, as mentioned by Dr. Mashta yesterday. After her talk, listening to her talk, I'm glad to hear that VTE is no longer one of the top 5. In fact, it's not something that we are too. It used to be top. Right. But why is it that PPH we're still not able to? Dr. Razia also pointed out yesterday, right? We still have mothers dying due to bleeding. That is something very disheartening, all right? But VTE has been dethroned from the top 2 spots as such, all right? And PPH deaths are often preventable. Talking about health economics, right? PBM is in the prime quadrant, meaning to say that you spend the least with the best outcome. The worst are those that you spend a lot and your outcome may not be as good. Okay? Or you spend a lot and you get good outcome, fine. All right? Okay? So for example, heart transplant, things like that. Okay? You spend a lot. All right? But PBM is something that you spend less and the benefits is across the board. So it's not very individual. Not individual, it's for everyone in the community. So coming to barriers and challenges. This is my thoughts about it. I feel that the biggest challenge that we have is actually knowledge gap. And because of lack of knowledge, we disbelieve, right? We don't believe it because Well, we think that we know best, right? And unfortunately, we also have a lot of non-evidence-based transfusion practice. But don't chase the number. Transfusion is not so good, right? And we have this inertia. No incentive. There's no incentive to change, right? But if you think about patient, that should be your motivation to change, right? And change, of course, come along with a lot more work, right? And my challenge now is I don't see much of interdisciplinary collaboration. Right? Who should drive PPM? I think all of us should be the driver for PPM. But unfortunately, in many countries, anesthetist is supposed to be the one driving PPM, but not so in Malaysia. But I'm very glad to know that my colleagues, my anesthetist colleagues in the College of Anesthesia are making it a point that they should take the lead from now onwards. So you see a lot of their talks is about PPM. We just had one, I just missed one yesterday because they were talking about it. Because of this conference, I could not join their talk. And of course, lack leadership, lack of budget, and misuse and abuse of MTP. What do I mean by misuse of MTP? Because MTP works so well that some departments tend to just call for MTP for the sake of getting blood sooner rather than later, when there's not really need to have MTP. MTP is massive bleeding, right? Okay, so when you have this thing, then people tend to like, unhappiness lah, negative feeling between the departments. So we need to invest more in medication options and newer technology. Medications, I spoke to, during the launching of our consensus statement a few days ago, about 5 days ago, we talked about the need to make availability of third generation IV drugs. In short, it's like monofil pharyngeal. Pharyngeal is not in the blue book. Pharyngeal lagi mahal. So let's talk about monofil, which is in the blue book. It's 3 times what we're paying for Cosmofil or Vinofil, all right? But it can be delivered in a quarter of the time, about 1 hour. Though for those of you who are familiar with Cosmofil, it can take up to 4 to 5, 6. When you prepare register patient, if you include that, it can weigh up to 6 hours. But monofil, in less than 1 hour, you can settle it. So it saves time. Right? I always say that, just because you are public patients, we don't respect your time. If I'm in private, I use monofil. Time is money, right? Isn't it? But it's 3 times higher, the cost. How about erythropoietin stimulating agents? I think we should start allow other departments to use and not just confined to nephro, to hemato. All right? And fibrinogen concentrate. So fibrinogen concentrate is on my wish list to YBMK the other day, that I would like to have fibrinogen concentrate for massive PPH management. Equipment-wise as well, we are not using enough cell storage. This VET, viscoelastic testing, including ROTAM and TEG, a lot of us are not having this as well. And we should start thinking of switching to microchamber or pediatric tubes. You may be wondering, why am I talking about all these little things? But it does contribute to cost cutting in future. But to change to microchamber testing is not so simple. Your machines and so on and so forth, right? And of course, we are thinking about adopting new parameters such as reticulocyte hemoglobin content. We have not been paying adequate attention to maternal anemia soon enough, all right? Because we are very reluctant to use IVIN, okay? And perhaps we should rethink about the target HB for pregnant women. I'm advocating for 13 instead of just 11. And we are not screening routinely for maternal red cells antibodies. And of course, I think the worst is we are not familiar with MTP. We still talk about the IVC regimes. In terms of neonatal anemia, I think we should start thinking about delayed cord clamping as such, all right? And don't do routine blood investigation. There have been studies that is done to show that any patients admitted to ICU within 3 days or more, they will become anemic because of their conditions, inherent conditions as well, but also because of your frequent blood taking. First challenge at individual level. What can you do? You have knowledge gap, then read up. Learn from people, learn from other departments that are using it. And the most important thing is that you have to be inquisitive enough to know. Do away with your misconceptions regarding the use of IVIN. Oh, it's dangerous, it's expensive. And you still use the IVC. When any maternal mortality meeting that I attend, and when they still mention about the IVC, I know that you are not having full comprehension about MTP. MTP replace your DIVC. And the FVC is not evidence-based, by the way, all right? And they are not the same. Blood transfusion, again, your practice. And shouldn't do routine blood investigation. Leaderships, I don't have buy-in from senior. So much so that I have people like you all, the juniors in the crowd, specialists and would be specialists soon, who may be finding it difficult to push for this forward because your seniors are not buying in. They are not convinced enough. So, but don't stop. Don't give up. All right. Show results. Okay. And other departments, again, as I mentioned, they are not aligned with our PBM effort. How do we start? It is actually started with this. We were hosting Dr. Jamila when I organized the first, I think it was the first VTE in pregnancy in Temellow, when I was in Temellow. So over the dinner, and she was talking, hey, you know, Carol, what do you think about the OJ? I was like, what PPM, you know? She was actually talking about clinical transfusion workshop as well. So there was a lot of initial skepticism, but the seed was planted. What I do learn after so many years, after being coming to this age, I learned to listen to people who are wise, whom you respect, right? I mean, of course, it doesn't mean I don't listen to others. And these people can be even junior to me, but Dr. Jamila is so wise. When she planted something, I may not react appropriately at that time because I dismiss it, but I think about it. All right. And that actually led to us starting to attend the workshop in Ampang, my current hospital. See how fate has it, huh? From Temellow, I went to Ampang. All right. So in Ampang, they started doing this and used to send every courses that she does, and she was doing every 2 monthly. I would say, Dr. Sharmila, chop. I did not say I don't want to through the same. Our very first. And we have come a long way. In this almost 10 years of journey, we have gone through a lot of roadshows, teaching, and so on and so forth, involving other departments as well. Until last year, we had a to organize this because I don't have a venue it's all fully booked, my auditorium and so on and so forth. So we went up to Penang. So where are we now? Where am I? I probably at possible to screen, all right? Does not have as good outcome as those who did not receive, but in a similarly dire situation. They have higher increased morbidity and mortality and adverse events. And blood is not cheap and certainly not free. Just because we manage. You go to private, they charge patient, by the way, and they don't pay blood bank. I was telling blood bank, you should charge them more lah, private. Okay. And blood supply is a challenge with aging population. So this was mentioned by Dr. Landsteiner, who discovered ABO grouping during the Nobel lecture. He was given a Nobel Prize for discovering this, and he actually mentioned this way back in 1930 that number of transfusion given is surprisingly large, and it may well be that the use of this technique has been taken too far, and I think we indeed had taken too far. So blood transfusion, as I mentioned, has a lot of potential risks, but downward benefits. Among all the risks, I just want I like all these, names, and then it make you remember. All right. So Trali la, Stream la, Taco la, TAGVHD la, graft versus host disease. Do you know that you can have graft versus host disease? After all, blood transfusion is a liquid organ transplant. Okay, so you can have these reactions as well. There are plenty. I'm just giving you a snippets of it. So what can we do? Bottom up, start doing with your individual patients. Prevent and treat, well, anemia. Screen for iron deficiency, not just anemia. So check ferritin, check your iron store. Then the rest is I mentioned earlier. And more importantly, guide your junior. Okay. Second challenge at institutional level. Ask yourself, what is your motivation? I remember when I was in Tamalo, my CT ratio, you know what is CT ratio, right? Cross match to transfusion ratio was like 4 point something, 5, 6. Your target is 2.5, right? But the moment I start PBM, it reduced because you don't really need to cross match that much. You certainly don't need to transfuse that many. So make your MTP work for you. Blood bank, preoperative autologous donation, all right? Anesthesia for acute normal volumic hemodilution. These are things that they can start to, they are one and the same, if you ask me. Put it simplistically. During surgery, you can have intraoperative cell salvage. It's just when you collect blood. One is collect, weeks before your op, months before your op. One is just before your op, collect blood, first ANH, and then save it, and in case you need to transfuse. Intra-op is when you have bleeding ready. Okay, so they are same, but a bit different. Okay, we don't have enough IOCS, we don't have enough self-salvage, right? And quite often we use it for general winners, but I think we should benefit it for other patients as well. Okay, and MTP in your cluster system, make sure your district hospital is aware of MTP. Guide them how to do it. I've done it when I was in Pahang, all right, of other hospitals without it's just a blood fridge rather than a blood bank. They managed to do it when you guide them step by step. This is a Tamalo data just to show. After we implemented somewhere in mid-2015, our blood usage dropped. The next year, we have actually more blood collected than usage. By 2017, you actually see that our collection has dropped from 8,004 to 8,001, but our usage has dropped even further. All right. So as I said, 2016 onwards, we become like Santa Claus. In blood bank, they have this certain KPI to maintain. Right. So you cannot have waste. You cannot waste your blood. Collected blood you cannot waste. So they started asking, we have surplus of blood rather than the one who was always begging for blood. Okay, so this is just a very quick benefits that you can see from the point of blood bank. Policymaker and MOH level, what is your third challenge? I need more new medication. I'm waiting for misoprostol to be put into a blue book for indication of prevent and treatment of anemia. I need fibrinogen concentrate, right? Funding, need more money, needless to say. And then I need a dedicated program, Dr. Zaliha. I need a dedicated program for PBM. I know I need to speak to BPP and as such as your, Safe Surgery, Safe Life program. You need a driver towards it, like thalassemia prevention, like BFHI. So unless someone take the lead, this is like going towards top down lah. But it's a bit difficult to move. Local guidelines and include in syllabus. I'm going to propose it to be in NPMC soon, the next review. So this is something on misoprostol. And you all know, especially for the FMS in the crowd, we monitor HB at 36 weeks. Our target is 6% for KKM. Selangor set it at 5%. There is a move probably to move it to even lower. So that means you should not have pregnant women at 36 weeks to still be anemic. My challenge is 36 weeks is too soon. So I'm going to shift the goalpost now to earlier. Because by the time you are treating number only, your anemic punya effect already set in. You already have FGA, FGR, SGA, all right? But this is something that I need to convince them to change. So these are the guidelines, fresh out of oven 4 days ago. So where are we now in this? Just now was about knowledge. This is about institution. Where are we? All right. Are we committed to change now and behavior changes as such? So the way forward is to embrace your PBM. All right. Scale of doability. I always ask myself, can I do it? We can certainly bottom up while we wait for KKM to be top down. And I don't like things to be KPI driven, but unfortunately, it has to be sometimes. What happened with KPI driven is that people on the ground do not understand why we are doing this. So when you do not know the why, you are not as motivated to do it. If you know the why, you don't wait for top down, you go bottom up. All right. So incorporate iron studies in national thalassemia screening. I think it has been done. It will be launched. It will be released soon. The revised thing, meaning it's not just when you screen for thalassemia, screen for iron deficiency because you have more iron deficiency than thalassemia. Makes sense, right? Same patient, but kerja thinking a bit different. But it's the same. It's all about anemia. Stop MTP, discard the IVC. Start practicing delay cord clamping for the sake of the babies. We need more self-storage, but if we can't buy, you rent. All right. We are in the midst of, these are new, in the midst of developing our iron deficiency CPG. We are not calling it iron deficiency anemia. We are doing iron deficiency because I think the focus has to be sooner rather than later. And we are setting target HB for anemia for pregnant women as 13. And of course, hoping that we can get more VET. And we are thinking of adopting routine use of reticulocyte hemoglobin content as for your iron study. It's a one-stop thingy because one step can tell you whether thalassemia or iron deficiency, all right, rather than multiple steps that we are doing now. And MSQH KPI if we can. So again, these are the three pillars that I showed earlier. As you can see, it's multi-pronged, multidisciplinary, multifaceted, and I need our colleagues to help us in achieving this. So expected outcomes by doing this, we will have improved maternal and neonatal outcomes with reductions in all this morbidity that I mentioned earlier. And certainly, I think we will be saving costs for KKM. So we will be hosting the second O&G PBM in August this year in Ampang. Seats are limited because, again, hands-on. All right. So do come join us. If you cannot remember anything, please take this slide. Take this picture of this slide. Join us. And with that, I would like to end my talk. Thank you very much.
Thank you, Dr. Kara, for your very engaging presentation. So I would like to invite Dr. Hashlina Awansu to give token of appreciation to Dr. Kara.
For the last plenary of our second National O&G MOH Congress 2024, we would like to welcome Senior Assistant Commissioner Aminuddin Dahlan from PDRM. SAC Aminuddin first obtained a diploma in business studies from UiTM in 1986. He then continued his studies and earned a bachelor degree in business management from UKM in 2004. Driven by his strong passion, he graduated with a diploma in public law from the University of Malaya in 2005. Dedication, loyalty, and commitment to the team over the period of 37 years have been demonstrated through various assignments in the Kedah and Penang contingents. He has been serving as the Chief Assistant Director Management of General Licensing Investigating Committee since August 2022 to the present. Please put your hand together for SAC Aminuddin Dahlan on the stage for his lecture entitled Certifying Maternal Death Procedure for PADI, PATI or Stateless.
Bismillahirrahmanirrahim. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. Lebih dahulu saya ucapkan terima kasih kepada pengacara majlis Okey, telah terima panggilan bahawa ada satu jumpa mayat. Jadi apabila kita sampai ke tempat kejadian tu, kita dapati ada satu subjek, iaitu kanak-kanak yang dikerumuni oleh semut 30 tahun lalu. Bila kita sampai menghampiri pegang subjek tersebut, dan subjek tersebut bergerak. Okey, tuan-tuan tengok, subjek tersebut bergerak. Padahal keliling tempat kejadian tu ada manusia. Dan pada ketika itu kita capai apa saja yang ada untuk kibaskan semut-semut yang keliling seorang kanak-kanak tu, dan kita terus angkat bawa kepada hospital. Dan di sana kita telah dimaklumkan budak itu masih hidup, kanak-kanak itu masih hidup. Dan susulan daripada itu, siasatan telah dijalankan, mendapati bahawa ada seorang perempuan, wanita telah melahirkan anak luar nikah. Dan kita telah berjaya kena pasti wanita tersebut, berjaya tangkap dan berjaya tangkap pasangannya. Kanak-kanak tersebut telah dilahirkan oleh seorang wanita yang cacat. So di sinilah peri pentingnya kenapa simposium ini diadakan, bagi menjamin keselamatan manusia, tak kisah sama ada wanita itu cacat ataupun bukan, dan sebagainya. Jadi suka saya cerita kat sini ialah pihak KKM telah mengadakan satu mesyuarat pada tahun 2012, iaitu mesyuarat tersebut mendapati bahawa terdapatnya laporan kematian ibu mengandung pada tahun 2010 dan 2011. 2010 sebanyak 50 orang, kemudian 2011 sebanyak 65. Daripada statistik tersebut, pihak KKM mendapati tidak ada data untuk nak buat kajian. Sebab semua kejadian-kejadian kematian tersebut tidak dilaporkan. Banyak kan tak dilapor. Tidak ada bedah siasat dibuat. Laporan mati ada tapi bedah siasat tidak ada. Bila tidak ada bedah siasat, tidak adalah data untuk nak mengkaji. Jadi di sinilah datang sekali lagi kenapa pentingnya bedah siasat dalam kes-kes kematian. Yang hari ini kita akan fokus berkenaan dengan kes-kes kematian ibu mengandung. Cuma fokus pada hari ini ialah berkenaan dengan warga asing. Jadi warga asing terbagi kepada 3, PADI iaitu pendatang asing dengan izin, PATI pendatang asing tanpa izin, dan stateless yang tidak ada negara. Sepintas lalu untuk tuan-tuan, data kematian yang kita ada pada tahun 23 sehingga Mac 24. Tuan-tuan tengok sini kematian dalam lingkungan kita kelaskan umur 1940 dengan 41 ke atas berdasarkan kesuburan sebagai seorang wanita. So dari data ni kita pengklasifikasian ini dibuat berdasarkan mesyuarat dan diputuskan 1940 dan 41 ke atas. Jadi PATI ada 4 orang. PADI ada 4 orang, PATI ada 9 orang. Itu dalam lingkungan 1940. Kemudian umur 41 ke atas ada 2. PADI 1, PATI 1. Jumlahnya sebanyak 15 orang. Saya bercakap berkenaan dengan prosedur siasatan kematian. Prosedur siasatan kematian ni bermula daripada Seksyen 328 Kanun Prosedur Jenayah, iaitu Kanun Akta 593. Cakap pasal kematian ni, dia bercakap berkenaan dengan maklumat yang diberi kepada pegawai polis dan pegawai polis akan jalankan siasatan. Dan apabila melibatkan pendatang asing, warga asing, ada prosedur dia. Pihak polis kena rujuk pada kedutaan. Dan bila rujuk pada kedutaan, macam mana kita rujuk kalau kita tak kenal pasti? Kena ada proses kenal pasti. Di situlah kita menghantar maklumat kepada kedutaan untuk kenal pasti sama ada didaftarkan dalam kedutaan-kedutaan tersebut ataupun tidak. Dalam proses nak mengenal pasti itu pula, kalau tak ada identiti, kita kena ambil cap jari untuk hantar kepada bahagian D6 untuk kenal pasti. Kalau ada rekod. D6 mana cap jari. Kalau ada rekod, kita boleh semak dengan Jabatan Pendaftaran Negara, kita boleh semak dengan rekod yang ada pada polis. Saya tak nak panjang kat sini. Inilah pengendalian mayat warga asing. Saya cakap tadi, identiti, kalau kena pasti, maklum. Tak kena pasti, ambil cap jari, DNA, semati, rujuk pada D6 JHJ. Semak. Kalau kena pasti, jadi masa semak tu kita hantar black notice. So-called black notice ni adalah satu dokumen yang digunakan oleh polis, hantar pada Interpol. Dan kalau dah kena pasti, kita rujuk balik kedutaan. Kalau tak ada, dan kita kena pasti pula rujuk sama dia Islam ataupun bukan Islam. So dalam proses ini, data-data ini adalah satu pengendalian mayat warga asing. Tapi untuk makluman tuan-tuan, suka saya maklum kat sini ialah pengurusan mayat, kita balik pada tadi minta maaf, kita balik pada tadi. Apabila tak kenal, dia ada prosedurnya dalam MyHealth. Ada prosedur dalam MyHealth. Dan daripada situ, kita boleh rujuk apa tindakan step by step, macam mana untuk ambil tindakan untuk sama ada nak melupuskan mayat tersebut. Ini Okey, kita tengok ini. Ini saya gunakan My Health punya. Tuan-tuan tengok. Tak keluar sini. Aminuddin. Saya dah buat. Yes. Dia tak masuk slide saya yang asal tadi. Okey, tak apa. Saya minta maaf, ada sedikit kesilapan slide yang masuk tadi. Tak masuk slide yang the latest yang masuk tadi. Slide. Minta maaf, ada kesilapan teknik. Yes. Tak nampak, tak dapat. Okey. Okey, saya ulang balik ya. Ini adalah dokumen saya kembali kepada mula. So daripada ini adalah beberapa dokumen yang kita terima daripada Ketua Pengarah Kesihatan Malaysia yang telah berbincang dalam satu mesyuarat memutuskan bahawa perlunya ada penambahbaikan di atas kekurangan prosedur kerana tidak ada bedah siasat dalam kebanyakan kes-kes kematian ibu mengandung atau ibu hamil. Dengan bertindak kepada satu surat ni, kita telah adakan mesyuarat bersama KKM dan seterusnya pihak polis telah menyediakan satu arahan pentadbiran. Dan dalam pentadbiran tersebut, kita dah kembalikan kepada pihak KKM untuk sama-sama bekerjasama untuk laksanakan prosedur tersebut. Ini dokumen yang berkaitan. So, jadi daripada dokumen tersebut, inilah garis panduan penentuan penyebab kematian ibu. Di antara yang digaris kat sini ialah setiap kematian ibu, sama ada kematian biasa ataupun kematian yang disyaki, perlu menghubungi perubatan bagi menentukan sebab kematian. So yang kedua, mesti sama ada warga Malaysia ataupun warga negara asing. Ketiga, wanita yang berumur 13 hingga 49 tahun. Tadi Dr. Karen dia letak situ 15 hingga 49. Saya ni 13, saya pun tak pasti sama. Tapi inilah data yang kita dapat daripada pihak KKM. Dan akhir sekali Section 3992 ini adalah laporan pakar. So laporan pakar ni akan ada konten ataupun detail yang mana boleh jadikan data untuk kajian. Kembali pada ini tadi. Sini data dia. Okey ni. Apabila kita terima laporan, polis ke tempat kejadian, dan pada semasa kita tempat kejadian, kalau pihak hospital pun ada, kita sama-sama ke hadir. Kalau tidak, kita akan bawa mayat tu ke hospital, sahkan kematian. Sekiranya tidak ada unsur-unsur yang syak, kematian biasa, tidak melibatkan apa-apa jenayah, unsur jenayah, maka kita akan mencadangkan pegawai polis ataupun pihak perubatan mencadangkan kes ini tidak disasat lanjut, rujuk kepada keluarga dan keluarkan permit kubur. Sekiranya ada, kita keluarkan PON 61 dan dapatkan laporan pihak hospital. Dan di sana apabila kita dah rujuk pada pihak hospital, kita tunggu laporan kimia. Tunggu laporan hospital. Dan dalam proses mendapat laporan hospital tersebut, kebiasaannya pihak hospital akan mengambil masa dan ada kalanya pihak hospital akan merujuk kes-kes ini kepada kimia dengan untuk mendapatkan bahan dengan mendapatkan spesimen-spesimen tertentu dan seterusnya merujuk pada kimia dan mendapatkan laporan balik, seterusnya membuat laporan penuh. Laporan penuh itu akan diserahkan pada pihak polis bagi melengkapkan kes tersebut, maksudnya siasatan kes tersebut. Kiranya kalau ada unsur jenayah, kita akan rujuk seterusnya kita rujuk pada coroner. Sekiranya ada kes, kita akan berinquest. Kalau tidak ada kes, rujuk pada TPR dan kalau TPR setuju, tidak ada siasatan lanjut, kita akan selesai. Sekiranya di TPR ataupun pihak pendakwa raya mendapati tak puas hati, dia perlu buat inquest, maka kembali pada inquest dan siasatan dijalankan, seterusnya ada keputusan sama ada kes jenayah atau bukan. Ini pada keseluruhannya, ini adalah carta liran untuk siasatan kes kematian, bukan untuk ibu mengandung sahaja. Okey, kita balik kepada prosedur siasatan kematian melibatkan warga asing. So pengambilan, tuan-tuan tengok sini tadi, seperti yang tunjuk tadi, pengenalan mayat. So kita kena pasti identiti, kena pasti rujuk pada duta, tak kena pasti ambil cap jari. Kemudian saya makan kepada agensi-agensi yang berkaitan, maklum Interpol. Kemudian kalau kena pasti, kita rujuk balik kepada kedutaan. Kalau tak kena pasti, kita rujuk pada pihak coroner ataupun magistrate. Magistrate akan menentukan sama ada kes ni boleh dilupus ataupun tidak. So panduan pelupusan ni kita rujuk kepada apa yang tertera yang dalam MyHealth kesihatan tadi. Ini antara panduannya. Pihak hospital akan membantu polis mengamankan pasti identiti dan pengesahan waris. Kalau jenazah Islam, jenazah akan terus disimpan dalam peti sejuk, simpan mayat sekurang-kurangnya 3 hari, sementara menunggu jawapan daripada usaha pengesahan waris yang telah dilakukan. Kalau mayat bukan Islam, mayat akan terus disimpan dalam peti sejuk sekurang-kurangnya 14 hari sementara menunggu jawapan daripada usaha pengesahan waris yang telah dilakukan. Sekiranya tidak ada waris datang menuntut, dalam masa tersebut, salinan permit mengubur dibat dan kelulusan untuk pengurusan terakhir mayat tersebut akan didapatkan daripada pegawai penyiasat ataupun magistrate. Yang saya kata tadilah, rujuk pada coroner atau magistrate tadi, kita akan dapatkan kalau magistrate benarkan, kita lupus. So laporan mayat tadi tak lebih daripada 14 hari diberikan kepada pengarah. Laporan keadaan mayat tidak dituntut lebih daripada 14 hari akan diberikan kepada pengarah hospital. Okey. Dan dalam kes ini juga, sekiranya ada usaha untuk laksanakan kajian akademik, inilah dia punya guideline dia. Mayat mesti bukan mayat orang Islam. Mayat yang tidak dituntut lebih 14 hari. Dan ada si mati semasa hidupnya atau waris si mati tidak membantah terhadap badannya digunakan selepas kematian bagi maksud pendidikan atau penyelidikan perubatan. Berdasar siasat ataupun inquest atau penyiasatan berkenaan dengan kematian di bawah kanun prosedur jenayah tadi, tak ada, dah habis, dah selesai. Tiada waris si mati yang masih hidup untuk menuntut mayat. Dan prosedur penyerahan mayat kepada pihak universiti adalah mengikut perkeliling Pengarah Kesihatan bilangan 5/2008. So ini dia guideline dia kalau ada nak buat kajian. Pelupusan mayat. Mayat yang tidak diketahui identiti, yang tidak dituntut akan diuruskan seperti berikut. Jenazah Islam ataupun dipercayai beragama Islam bersama dengan pemilik kubur diserah kepada Jabatan Agama Islam bagi tujuan penguburan. Ini yang tak dikenal pasti ni. Bagi mayat bukan agama Islam, kita akan serah kepada persatuan agama yang dipercayai, dianuti semasa hidupnya bersama dengan pemilik kubur bagi tujuan pengurusan terakhir mayat tersebut. Inilah dia punya guideline dia. So berikut adalah perkeliling Ketua Pengarah Kesihatan bilangan 5/2008. Itu saja yang saya nak bagi tahu berkenaan dengan certifying maternal death, prosedur untuk PATI, PADI dan stateless. Selain daripada itu, saya tidak bercadang untuk bercakap panjang. Sekiranya kalau ada pihak tuan-tuan atau doktor-doktor nak bertanya, saya sudi menjawab. Terima kasih.
Thank you, SAC Aminuddin, for your very informative talk. I would like to invite Dr. Rozia to give a token of appreciation to SAC Aminuddin. Moving to our industrial sponsored session by GSK with the topic Newborn, the Critical Role of Maternal Immunization. The lecture will be delivered by Dr. Michael Hong, Maternal Fetal Consultant, Sabah Women and Children Hospital. Without further ado, let us welcome Dr. Michael.
Selamat pagi kepada tuan-tuan dan puan-puan. Tahniah kerana masih datang dengan penuh semangat on the last day of the conference. And yes, you deserve a big clap for yourselves. And I understand that we are in the midst of a very heavy topic this morning. We are talking about maternal mortality. And after breakfast, we are continuing to talk about maternal mortality. So I hope before breakfast, give me some time to lighten your heart a bit so that you can enjoy your breakfast. I will be talking to you about bridging the pertussis immunity gap in newborns. It sounds a bit complex, but let me break it up into something simple and smaller for you. By the way, I'm Dr. Michael, working in Sabah. And this is the view of Kota Kinabalu, Sabah. And if you have not known, I hope you have known by now, OGSM Congress will be held in Kota Kinabalu in July this year, in a few months' time. So I welcome you to join us for this event in KK. And this is a hospital that I work in, Hospital Likas, also known as Sabah Women and Children's Hospital. Right. A bit of disclosure, this is a industry-sponsored CME supported by GSK, and But the views and opinions and most of the things that I'll be sharing with you this morning are of my own curation. Right? Let's get on with it. So, what is the problem? If you have been attentive to the news sometime last year in August 2023, this news hit the headlines, right? 23 deaths due to whooping cough. And these are the various names that we call this disease. You can call it whooping cough, pertussis, batuk kokol, 百日咳, which translates into 100 days of cough. And the last two, kalau tak silap, kakuven iruma. Tak tahu lah betul ke tidak, right? And more news on the topic, especially in my home state, yeah. And whooping cough is on the rise in Sabah as of August 2023. And majority of the cases involve babies that are under 1 year old, right? And Sabah had the most number of cases. But as you can see, it's not just a Sabah problem. Okay? The numbers are followed by cities like Selangor, Kuala Lumpur, and Putrajaya, where we are now. And as of the progress that we last heard, our ministry was seeking an allocation from the finance ministry to provide KIDAP vaccines for pregnant women. So some quick facts about this disease, pertussis ataupun whooping cough as we call it. It is caused by the bacterium Bordetella pertussis. It causes severe uncontrolled coughing in the child. It spreads easily by respiratory droplets. We confirm the diagnosis by doing a nasopharyngeal swab PCR, like what we do for COVID-19 those days. We do have an effective triple valent vaccine available, triple antigen vaccine. And we do have a vaccination program in KKM, which we vaccinate our children at the early months of age. Right. My slide got checked. To play a recording of what whooping cough sounds like, but it seems that it doesn't really come out well, the audio, right? So there are 3 stages to this disease. In the first stage, known as the catarrhal stage, which happens about 1 week after getting the bug, right? The symptoms are like most any URTI in the child. You get fever, you got a bit of running nose, occasional cough. But the disease progresses into the next stage, known as the paroxysmal stage, where you have this child giving a long cough, and at the end of this cough, the child have gaps for breath with a whoop that sounds like and that's where the name whooping cough comes from. Right? And this may last up to 1 to 6 weeks, and some may even extend up to 10 weeks. So you see, it's quite a long course of disease. That's where we get the name 100-day cough for this disease. After that, hopefully the child recovers and enters the recovery phase. Right? But during these few months of recovery, actually the child is still susceptible to other chest infections. And do keep in mind that babies less than 6 months old may not have the strength to have these gaps, this whoop. They may just stop breathing and turn blue and cyanose in front of your eyes. Right. So we are giving the vaccine. Why are we still having this problem? Right, let's look at our national immunization program, Jadual Imunisasi Kebangsaan, and this is the current thing that we are doing. And we focus on pertussis, which is given as part of this 6-valent vaccine to our children. Right? We give the doses at 2 months, 3 months, and 5 months of age, and a booster dose at 18 months. But do you notice the gap there? This is the gap that I'm trying to tell you. The first 2 months of life, what is there to protect the babies from pertussis? And so let's do something smart. Why not we shift the first dose to give it at birth then, solve our problem, right? But studies have shown that it's not appropriate to give this vaccine to the newborn because it doesn't really work, right? So we have our babies unprotected for the first 2 months before they receive their own vaccine at 3rd month of life. And you get this kind of thing on the news. And this just happened 2 months ago in Kelantan. A 2-month-old baby dies of whooping cough. I'd like to draw your attention to this paper published in our own country, in Malaysia, a hospital-based surveillance study. You may recognize some names on this paper, or even your hospital may be involved. Yeah? It's a 1-year-old study, a multi-hospital-based prospective study, right? And they try to answer this question. Let's say you have a child hospitalized for respiratory tract symptoms, right? Hospitalized child less than 6 months old. What are the chances of this child having pertussis? Right? And they have 440 samples. 13% of these child were diagnosed by lab tests on PCR to be having pertussis. And the even more shocking fact is that almost 90% of them are below 2 months of age. Again, the immunity gap. Right? So conclusion from this study, pertussis burden is still high in our children in their earliest months of age, and it is important to vaccinate mothers and the babies. Okay. Pertussis is not just any respiratory tract infection. It causes significantly higher rates of complication and mortality. And newborns are particularly vulnerable. Okay, what complications am I talking about? Hospitalization, pneumonia, cyanosis, apnea, seizure, and encephalopathy, and even death. Right. I'm not a pediatrician, I'm an obstetrician talking to you today. So last week, before I came to this conference, I met up with our ex-ID boss, Dr. Fong Siu Moi, who happened to be one of the authors of the paper which I just shown you. I told her, Dr. Fong, I'm going to talk to obstetricians about this disease or this vaccination. What are some key points that you would like me to tell them? So these are the words. Our babies younger than 3 months are the ones that are most likely to die. Right? Neonatal vaccine is not in time to save them. And if this maternal vaccine has been proven to work in other countries, then we should really push for it and go for it. Right? This bacteria is very common. It's among adults, just that we have not done enough tests to diagnose it. And it damages the baby's lungs, and the sequelae long-term is very damaging. These are the words from our previous ID boss pediatrician. So do we have a solution, ladies and gentlemen? Yes, we do. And it's called maternal vaccination. Right? Why vaccinate in pregnancy? Dr. Jamia, Prof. Jamia, my lecturer in medical school ages ago, has given us a wonderful overview of vaccination in pregnancy yesterday. So basically, we can divide why we vaccinate mothers in pregnancy into the purpose, whether we want to protect the mother, or do we want to protect the baby, or we want to protect both parties. But also we can divide vaccination into what we don't give, and it includes live attenuated vaccines like MMR, varicella, HPV, vaccines that we are encouraged to give, such as influenza, pertussis, diphtheria, tetanus toxoids, which we are giving routinely, inactivated polio, and there's another list that can be considered giving if the situation arises. So the subject of interest that I'm talking to you today revolves around these three items, which is something that is encouraged to be given during pregnancy. Okay. I believe after COVID-19, we have moved away from the belief, or rather the misconception, that vaccination is dangerous in pregnancy. Right? So mothers can provide passive protection to their babies in the earliest months of life. How does that happen? Right? The first way is through transplacental transfer of antibodies. When you give a vaccine to the mother's body produces antibodies, and IgG form of antibodies get transferred to the baby through the placenta. And when the baby is born, sudah sedia ada antibody dalam badan dia. Right? That's one form. And by the way, do you know that this process is an active transfer, right? Which increases as the pregnancy progresses. Reach a peak concentration in the baby about 33 weeks of age. And when the baby is born at term, actually the concentration of antibody is higher in the baby compared to the mother. Okay. The second form of transfer of protection is through breast milk. Right? Antibodies in the form of IgA and IgG are detected in the mother's breast milk. So therefore, we promote breastfeeding to provide this protection to the babies. But whether this is an effective method to protect from illness, studies are still required to prove that point. Ladies and gentlemen, there are two vaccines available for maternal vaccination of pertussis. The first is known as the DTaP, DTaP vaccine. This is the vaccine that we give to babies, infants, and young children, and this is what we give according to our immunization schedule at 2, 3, 5, and 18 months of age. And the other vaccine that we give is a Tdap vaccine. And this one is given to adults, recommended to give one dose every 10 years. Look at the wordings. Why are there capital letters? Why are there small letters there? Okay, basically, it means that capital letter means it's a full strength concentration, whereas the small letter, like the small p, means it's a reduced concentration. And the A in the name means it's an acellular vaccine compared to a whole cell vaccine. Right? So if you have trouble remembering these names, like I do, so DTaP, and this is DTaP. And Tdap is one of the parties that we always blame for everything that goes wrong in our country, if you get what I mean. All right, there have been countless studies on this topic, right? So I'll just draw your attention to this statement on vaccination in pregnancy against pertussis. And this is something quite recent, baru published in 2022. And they have collected pertussis experts from 18 countries, including Negara Barat, USA, Canada, okay, the Americas, Argentina, and Asian countries, India, South Africa, and was involved. So it's a worldwide recommendation. And what do they say 2 years ago? Right? This vaccine is safe. It is highly effective to protect the babies. They recommend that this vaccine should be given early in the 3rd trimester, and maybe can be even given earlier in the 2nd trimester, but more studies are required to prove this point. So where do we move on from there? Okay. So this is an interesting paper. Prof. Jamia has shown you a snippet of it yesterday, but I would like to go into a bit more details to share with you. So once upon a time in UK, right? In 1957, the childhood vaccination program, program suntik anak-anak dengan vaksin, it's not something new, started negara kita merdeka tahun tu, right? So they started giving routine vaccination to the child, and Malaysia started 1 year later in 1958. And in the past, they have been giving just for the mother, right? And look at the chart on the y-axis is surveillance data of infant death, kematian anak, right? So what happened in 2022? There was an pertussis outbreak in the UK. Numbers shot up 10 times compared to the previous years, right? And look at the chart, kematian anak meningkat, went through the roof. So there was an emergency need to do something to solve this problem. And therefore, in 2012, UK started to vaccinate their mothers against pertussis. They started with 28 weeks to 32 weeks immunization. Later in 2016, they started to immunize even earlier, from 16 weeks. Right? And look at the data. What can we conclude after implementation of this program? Firstly, even though there's a maternal vaccination program, there is still mothers who are not vaccinated for various reasons. Either the healthcare system failed to reach them, or people just don't want to vaccinate. But look at the kematian anak-anak. So among the babies where mothers are vaccinated, the infant death has much reduced into that two cases in dark green. And these two babies died to mothers who received the vaccine very, very late in pregnancy, about within 1 week before the mothers deliver. So based on this information, conclusion made, anti-pertussis vaccine given to the mother is highly effective to reduce infant hospitalization and infant death. And if we do start vaccination earlier, more mothers get vaccinated. When is the best time to give this vaccine? So many people have discussed about it. Should we give it in the 3rd trimester, 2nd trimester? Why not 1st trimester? Lagi awal, lagi bagus kan? So some things that we need to consider. All right, when you inoculate this vaccine to the mother, it takes 2 weeks for the body to mount the maximal response. Right? Second point, 1st trimester is usually associated with organogenesis, miscarriage. So if you give a vaccine and something happens, the vaccine gets the blame out of it. So people are a bit more cautious giving vaccines in the 1st trimester. The third thing to consider is when is the best time for this transfer of vaccine to the baby. Right? If you give too late, let's say you give at 34 weeks, it takes 2 weeks to develop a good response. But let's say baby preterm birth, beranak awal, terlepas sudah transfer of this vaccine, these antibodies to the baby. So somebody thought of the great idea. Why not? So many questions, let's do an experiment. So there's this paper published in the Lancet. It's called the Optimum Study. Just last year, six hospitals in the UK was involved in this study, and it's an interesting study. They selected women who have not received vaccination in the current pregnancy. They divide the timing of vaccine into 3 groups. The first is the early administration group, bagi vaksin sebelum 24 minggu. Okay. Second group, somewhere in the middle, bagi vaksin 24 sampai 28 weeks. And the third group, bagi vaksin lambat sikit at 28 weeks to 32 weeks to see whether it makes any difference or not. Right? The patients are divided into 1:1:1 ratio. Right? So they had 330 samples, and this is the finding. So the 3-color bar, as you can see, red is the early vaccination group, blue is the tengah-tengah group, and green is the late vaccination group. Right? And on the x-axis is the 3 antibodies against various components of pertussis. And it is found that it doesn't really make much difference. Right? When the baby is born, they take the baby cord blood and test the blood for antibody concentration. And it's found that whether you vaccinate early, middle, late, in the end, baby gets quite similar amounts of antibodies in the body. Of course, you can say ini tak aci ni tak laku ya. We want to look at evidence of protection. You measure antibody doesn't mean it protects the baby, but unfortunately, we do not have that data yet. So this is taken as a surrogate information to make clinic decisions on vaccination. Conclusion: we can vaccinate even from 16 weeks itself, and it all works well. Okay, so is it cost effective? We are going to spend money buying vaccine, right? We hope to reduce hospitalization of babies, infants especially. Is it worth the money or not? So this calls into a cost-effective analysis, right? And there's this paper from the UK in 2021. They have measured the ICER, and the conclusion made there is some maternal pertussis vaccination program is cost-effective. Right? We are not just measuring money to money. Remember, when the child is admitted, baby kecil, 2 bulan umur dia, masuk hospital, kamu admit 1 orang ke 2 orang? 2 orang kan? Mama dia pun ikut bahkan. Ya. So mama dia ikut anak. Siapa jaga anak-anak lain di rumah? Mama dia tak dapat pergi office. Siapa cover on call dia? Kerja dia. Kan? Yeah. So we are not even taking account into the long-term sequelae of this child that's going to get from pertussis. Recommendations on this vaccination: keep things simple. Recommendation: 1 dose of vaccine, Tdap vaccine in each pregnancy. When do you give it? If you listen to what the British say, 16 to 32 weeks. If you prefer to listen to what the United States says, 27 weeks onwards. And every pregnancy, you give a booster dose because this immunity does wane off with time, right? And this is not just satu dua orang cakap, is recommended by various national professional societies. Some of them you may recognize, like the WHO, NHS, CDC, RANSCOG is there, ECOG is there. So what choices do we have? We have actually 2 choices of Tdap vaccine to give to our antenatal mothers. The first is Boostrix by GSK, and the second is Adacel by Sanofi. Yeah, I'm finishing soon, so don't stare at me. So okay. So I was asking the GSK rep, hey Brian, why you come all the way to Sabah to look for small, low-profile speaker to talk about your product when you have so many good speakers you can tangkap at West Malaysia, right? So this is what he showed me. Sabah punya road tidak bagus. Mau pergi kampung-kampung bagi vaksin, kadang-kadang 1 hari 2 hari tak sampai. So the advantage of this drug is it is stable. When you take it out of the cold chain, it remains stable for up to 7 days in room temperature. So are we getting it free anytime soon? Soalan cepu emas. Yes, good news. Yes, we are. The question is when. So ada sidang media daripada Menteri Kesihatan Ogos 2023 yang menyatakan bahawa kita akan meminta 25 juta ringgit. Kita nak minta bagi vaksin kepada ibu-ibu mengandung termasuk yang bukan warga Malaysia. Okay, kita nak bagi dari 13 sampai 36 weeks. Dan kita plan nak kasih jalan program ni tahun 2024. tuan-tuan dan puan-puan, tahun ini tahun apa? Sudah nampak vaksin tak? Belum ya? Ya, itulah. So, yeah, if you have umur macam saya, you will remember this song, ya, ciptaan Adam Ahmad, lirik oleh Wan Aisyah, lagu slow rock, ya, 1990-an, yang memenangi anugerah juara lagu. Nak saya nyanyikan tak? Nak takut rosak appetite breakfast nanti. Hati membeku mengingatkan kata janji manismu. Oh. Bolehlah kan? So, tuan-tuan dan puan-puan, are we looking at the case of janji ditepati ataupun janji dicapati? And I have some good news for you from our vendor that our chapati is almost ready. Right? The tender process has completed sometime a few weeks ago, and we are on track to receive this vaccine in KKA sometime in October this year. Oktober tu berapa bulan lagi? So what can you do in the meantime? Okay. You dah listen to my talk, encourage you to talk about it, to tell your patients about it. So it's not free yet, but it's available for purchase at private clinics, private hospitals. So may I suggest, if you are pregnant today, or you are the sister atau BFF yang pregnant, and you have some money to spend on activities like this, like this, like this, would you consider spending your money on this to protect your precious one? Yeah. So my closing slide, tuan-tuan dan puan-puan, healthy childhood begins in the womb. And with that, thank you for your kind attention.
Thank you, Dr. Michael, for bringing us the importance of maternal immunization.